This is Masuda over here from Karachi, Pakistan.
Walk करो ये जो है ना आगे निकलो तो बंद काल में बोटियां खेलेंगे तुम्हारे हाथ से
देखो ना हम वही देख रहे कौन सा काम कर रहे हैं
ये देखो इससे शादी करवा देंगे देख लो
मैं पांते लगा
देख लो हाँ क्या दिया है सुनो तो मैं क्या बोला था आज अपने को विटामिन डी पीना है
मैं दूध ला रही हूँ गरम करके
हाँ दूध है फुल वैल्यू है फुल वॉल्यूम में पहले बताओ क्या ठीक है एक्टिविटी आज आयरन खाओगे खा लो हाँ कल से खाओ तो दूध का टाइमिंग भी यही रहेगा आयरन का तो अंदर खिचड़ी बन जाएगी तो दूध दोपहर में शाम को पी लिया करो शाम को पी लो ज्यादा बेटर है नारे कोई काम नहीं है आप तो भाजी पाला बना लो
person who has been kind and faithful to us, Jehovah God, who live in this land. Father, we are saying thank you because in this land you have given us favor. We have found favor with men, Jehovah God. Our children have found favor. We have found favor, my Father. We know there are those who have been here, Jehovah God, and they left prematurely. Jehovah God, but you have sustained us, my God. Lord, we are saying thank you for this night. Jehovah God, even for this night, we surrender everything, every plan, all that we will do, Jehovah God. We give it up to you. Bless the food, sanctify the living this night, preserve us, Lord, in Jesus' name. Amen.
Good evening to those that have joined quite early. So we will be starting at 7 p.m. Central African time, and then it all depends on your time zone, what time is applicable to you. But we are at 2 hours ahead of the Greenwich Mean Time. I kindly ask those participants that have joined that may you kindly mute your microphone. So for the remainder of the presentation, once our presenter starts, all mics will have to be on mute. At the end of the presentation, we'll kindly ask for any contributions, questions, observations, or advice. So for those that have joined early, I welcome you. Let's just be patient. I think we should be starting, according to my watch, we are probably 6 minutes away from starting. Thank you.
Hey, what's wrong with you?
Hi.
She's a
Hi,
woman.
Good evening. Hi, this is Mr Sheikh from Karachi, Pakistan. I want to know, can we invite other members who are not in this group to join the meeting?
Yes, ma'am. Hello.
Hello.
Yeah, you can with pleasure. We need all people to learn, so invite them. Kindly do so. Invite them.
If they are not in this group.
No problem. Invite them.
Okay, thank you.
Welcome.
Okay.
Hello, Mr. David. Okay. Okay. Okay, that's fine. Yeah, but the saying host is disabled attend this screen sharing, so you can add me so that I can share this. Okay. Okay. Hello, Mr. David.
Hello.
Hello. Yes, I can
Are you
hear
seeing
you.
my presentation now?
Yes, I can see your presentation. So I think you can press F5 so that we see the first slide only.
Okay. Are you seeing the first slide now?
Yeah, but you haven't started the PowerPoint show, not so. But I can see your slide clearly.
So I press what?
F5, I think, or just say start from the beginning.
Okay, F5. Are you okay?
No, not yet. Or just use the mouse to, like to start the presentation from the first slide.
I'm at the first slide now.
Okay, no, that's fine. That's okay.
Are you seeing my case now?
Can you hover it around your name?
Yes, hovering. Is it coming?
No, I can't see your cursor.
You're not?
No, I can't see it.
Okay.
David, are you using the computer?
Are you seeing it now?
Yes, now I can see it. Because if I see it, then I guess everyone else now can see it.
Okay. Now, you're not seeing it again?
I can see it.
You can see the cursor now?
Yes.
So that's fine now.
All right, so I think we are 2 minutes away from starting, or a minute.
Okay.
Let me
Okay.
see how many people we have. We have about 19 participants. There's a hand that has been raised by Techno Spark 5 Pro. Techno, please speak to us.
Yeah. Babaraki. We never baraki. You can hesitate.
David,
Yes.
can you hear me?
Yes, I can hear you.
Okay. Masuda wanted to invite some people. I don't know whether
Yes.
she managed.
I believe she
From
did so,
Pakistan.
because yes, we gave her a go ahead to do that.
All right. I don't know whether she managed. She has muted her audio.
So I'm sending the password, meeting ID and the passcode to
Okay,
other
for them
friends.
to join. Okay. That's fine.
All right, so the time is 7 p.m. Central African time. I would like to welcome everyone else that has managed to join at this time. My name is David. Today we have a presentation from Mr. Chitumba last, and the topic for tonight is inflammatory response and its significance in medical ultrasound diagnosis. The presentation is likely to take about 40 minutes. And thereafter, we shall open for any questions, contributions, or additions. I'll kindly ask that all participants mute their microphones so that we may listen into the presentation. Let's make sure that our microphones are muted, because we're going to record this, and then if we post it, it's going to have all the feedback in the background. And once again, I welcome everyone who has made it possible. Our presentations are held every week on Thursday. So the link is shared on various WhatsApp groups, or possibly even for those that are on Facebook, they may see this link. So please look out for the next presentation, which we shall be having next week on Thursday. At this point, kindly allow me to welcome Mr. Last Chitumba to give us his presentation. Mr. Last, it's all yours. Thank you.
Okay, welcome everyone. I hope you are blessed from all corners of the world. My name is Mr. L. Chitumba Canelo. I am broadcasting from Zimbabwe, Midlands Province. I found interest in the inflammatory response. I want to share how the inflammatory response had a bearing in medical ultrasound diagnosis. So I'm going to be slow so that everyone else is going to appreciate how do we link the inflammatory response to a diagnosis that you're going to make using a probe. So if you understand the inflammatory response, you can basically make the best out of your probe in terms of making a diagnosis. So before I start, let me just say, there is a nomenclature that used in the practice of medicine to name inflammatory condition or diseases. There is an adoption from the Greek word or the Roman word, the Latin word, sorry. The Latin word says itis. So the word itis pertains to inflammatory conditions or inflammatory diseases. We do have got examples like pancreatitis. We do have got examples like appendicitis, cystitis, So if you see those conditions with an itis at the end as a suffix, it basically means it is an inflammatory process. So there is a link between the physiology or the pathophysiology of the inflammatory process and the ultrasound features that arises as a result of the process of inflammation. So I'm going to take a stepwise to link the two so that everyone else can then understand how to make a comprehensive diagnosis using a probe when it comes to an inflammatory process. Okay, so here I'm going to briefly explain what is an inflammatory response. So in brief, an inflammatory process is a fundamental response by the body to tissue and injury. So when we have got an injury from endogenous or an exogenous stimuli, your body will not lie idle. It's going to respond. So the response that it makes to an inflammatory process or stimulus is what is called the inflammatory response. So basically, there is a man, a Roman man, who lived in the 1st century AD. His name was Cornelius Celsius. He coined, or he described the inflammatory process as having basically 5 cardinal signs. I want you to take note of the cardinal signs of inflammation. I want you to take note of these 5 cardinal signs of inflammation. They have got a huge bearing in terms of how we are going to make a diagnosis of an inflammatory process. So I find these 5 cardinal signs of inflammation very useful when we are now holding a probe, trying to figure out if there is an inflammatory process that is taking place. So you don't
Mr.
just
Chitumba,
hold your probe and say, hello?
Mr. Chitumba, sorry to interrupt. Your slides are not moving. I think we are still on the initial slide.
You're still on the initial slide?
Yes, we cannot see the other slides.
Are you? It's not moving.
We
No,
are on
it's
the
not
first slide throughout.
What?
We are on the first slide that introduces the topic, inflammatory response and its significance in medical ultrasound.
Yes,
Yes,
now
now it's working.
No, now it's
moving.
working. Yes.
Okay. So should I? So I can present without putting a full screen. I think I'm having an issue when the screen is full.
No, don't.
Can you see from this end?
Yes, we can.
Can you see?
Yes.
Okay. So here is where I am. I'm basically explaining what is an inflammatory response. I said an inflammatory response is a fundamental type of response by the body to tissue disease and injury. When there is a stimuli, either from exogenous or endogenous agents, the body will respond. This is what we are talking about, is the inflammatory response. I was saying that there was a Greek writer who described the inflammatory response as in having 5 cardinal signs. So it is these 5 cardinal signs which are very critical. If you are going to understand the 5 cardinal signs of inflammation, it means your diagnosis of any inflammatory disease or condition is going to be very easy. So when you hold your probe armed with these 5 cardinal points, your life is going to be very easy. So let me describe in brief the 5 cardinal signs of inflammation and make a brief link or relation to an ultrasound diagnosis from the images that you are going to acquire. The first sign is what is called redness. Redness is also or rubor, redness of the skin or rubor. This is also called erythema. So basically, when the tissue is inflamed, the tissue becomes red. So when you are inflamed on the surface of the skin, you can actually see this redness. So basically what causes the redness? When there is an inflammatory response, blood tends to move towards the process of inflammation, the place of inflammation. I'm going to explain how then that happens. So the movement of blood that happens is the one that causes redness. So when blood is moving towards the inflamed site, or when there is an increased movement of blood towards the inflamed site, you see redness. But when you're holding a probe, then what happens is you are going to see hyperperfusion at the site that has been inflamed. You see hyperperfusion or hyperemia. So this cardinal sign is very critical. Why do we need Doppler interrogation when we have an inflammatory process? It is because we want to see increased perfusion of the affected tissue that presents as hyperperfusion or hyperemia. So when you're holding a probe, when you suspect an inflammatory response or process, put color Doppler. If you see increased perfusion, because you cannot see redness from the outside, when it's an internal organ, you can see hyperperfusion. The second aspect, the body that is affected is going to show signs of increased temperature, which is heat, which is also called color. How does the color happen? It is because the tissue involved is having increased flow of blood, the vessels are dilated, then you are going to see a thermionic effect whereby there is going to be heat. So when heat happens, that's where you can say maybe the patient is having fever. It is because of this inflammatory response. So also heat is due to an increased flow of blood on the target tissue or the inflamed tissue. So this is another sign of inflammation. The third aspect or the third cardinal sign of inflammation is swelling, which is called tumor. Then what happens with swelling? Basically, when the tissue is inflamed, I'm going to explain this below in detail. When the tissue is affected, it swells. What causes the swelling? I'm going to highlight it as we go down. When the tissue swells, it basically means the target tissue is going to have an increased size. So basically, an inflamed organ or inflamed tissue, it shows an increase in size. That's why we are going to say that seeing an inflamed kidney, it has got an increased size. That's why we measure the size of the kidney to say it is swelling. That is a signal, a sign of an inflammatory process. So as we
Mr.
are moving,
Chitumba.
I want to take, hello?
Once again, hello, Mr. Chitumba. Can you hear me?
I can hear you. Yes,
Yes.
I can.
Yeah, so the slides, the slides again, they're not moving, and I think it's not showing the entire slide on my screen. I think it might be applicable to everyone else. I think just toggle between full screen.
Appearing now?
The slides are not moving. Just toggle between the full screen and then a minimized screen. Like just move. Not from my side. No, I can't see. It's almost like your screen is frozen. Yeah, but can you reduce the slide? Mr. Chitumba, could you? We are still on slide number 2. So what I wanted to suggest, can you move,
That's
minimize?
where I am too. That's why I am.
Yeah, but can you try and
on slide number 2?
Yes, can you try and minimize the screen size, like minimize it and then you maximize it? Because slide number 2, it's not showing, it just shows not the entire slide.
Okay.
So
okay, let me try.
I think, David, maybe it's on your computer, because I can see inflammatory response and
You can see
the
it.
5 signs that, yeah. Now
Oh,
he has
okay.
made it smaller. It's fine.
Okay, no, it's fine, Mr. Chitumba. You can proceed.
Okay, thank you.
Sorry for
it's a computer. Okay, that's fine.
Mr. Chitumba, can you please go on slideshow so that we can see your slides in slideshow? They are
Okay.
on edit mode. Yes.
Are you seeing?
Yes, we can see. But
Hello?
I think it will be better
I'm
if
now
you go on the
slideshow.
slideshow. Yes.
Are you seeing?
Yes, it's clear. I think, Mr. Chitumba, the person concern was for you to go to slideshow, but I think that's where we lost you without having the pointer. So I think just do it like that because we can still read. I think it's legible enough.
Okay, that's fine.
Thank you.
So I was talking in terms of the swelling. I was talking in terms of the swelling as one of the cardinal signs of inflammation. So I was saying, how do you see swelling on ultrasound scan? That's where you are going to say the organ, the target organ, is actually enlarged. It is because it's a sign of inflammation. And the second last cardinal sign of inflammation is pain, which is low. That's why I'm putting this picture here. When a person is having an inflammatory condition, they experience pain. What causes this pain is because of the inflammatory agents like the histamines which are produced. I'm going to explain briefly how that happens. At the same time, when the tissue is swelling, because it's going to compress the nerves around the surrounding nerves, so you can feel the pain. So this is another sign of inflammation. If you compress on sonopalpation, that's where you can say the patient is having tenderness. That's the hallmark of the Muffe sign when you're doing a scan of the gallbladder. Because when you compress a bit, you're saying the patient is feeling pain. The same applies when you're having when you're scanning the appendix. Then the patient is having a rebound tenderness because of this pain that is induced by the swelling of the organ that is now having a bearing on the surrounding nerves. The chemical agents of inflammation also causing or inducing the pain. The last cardinal sign of inflammation is loss of function, we call functional lysia, because the body does not want the infection to spread to other parts of the body. The pain is going to be localized. So when the pain is localized, it means the target organ is going to have a loss of function, which is called functional lysia. This can be good when it resolves quickly because the target organ will have the normal function, or it is going to restore its function. Unfortunately, when this is not restored or the inflammatory agent continues like to chronic stages, the target organ is going to die permanently. So you can see necrosis of tissue. At the same time, you can see final infunction. That's the way you are going to say now, I am seeing signs of chronic renal failure is coming from loss of function. Our normal kidney is no longer functioning. So this cardinal sign, you see it when you see the target issue is fibrosing, when you see the target issue is undergoing necrosis. Your target organ now is more hyperechoic, and you can actually shrink because of loss of function. You are now saying my organ is showing signs of necrosis because of the fifth cardinal sign of loss of function. Okay, so here is a diagram that is trying to explain the inflammatory response in short. Okay, so here we are having a target skin that has been ruptured. So the first thing that happens when your skin ruptures, the tissue is then damaged. There's going to be a capillary exchange when bacteria enters. The capillary exchange that happens is your body tries to release leukocytes into the extra vascular space. So basically, there's fluid that's going to move from the capillaries into the extravascular space. It's taking with it the macrophages, the leukocytes, to contain or to fight the target pathogen. So tissue damage, capillary damage happened, bacteria enters, then we have what is called the neutrophil activation. Neutrophils are just types of the white blood cells that are going to fight the invading bacteria or endogenous or exogenous stimuli. So when these neutrophils are activated, they are going to fight off the bacteria involved by a process which is called phagocytosis. Then when this happens, the phagocytes are going to produce debris. So the dead or broken bacteria, it collects as debris. So this debris now, you can see it in various or manifesting in various forms in an inflammatory process. I'm in detail how that happens. So when this debris now happens, it needs to be removed from the target organ or the place of inflammation. So the complement activation is going to take place at the same time. Your monocytes and the macrophages, they continue to digest the debris. So when this happens, the complement is activated. We are going to have a production of immunoglobulins, which are trying to clear the bacteria and the debris from your skin. So when these monocytes now,
Mr. Chitumba, once again, the slides are not moving. We are still stuck on slide number 2. We are not on 3.
2 or 3?
We are
on
still
3.
on 2. No, we can only see 2. From my side, I can see 2. I'm not seeing slide 3 now.
It's not moving.
No.
It's not moving.
No,
I can. 2.
Okay.
We are still
Is it moving
2.
now?
Yes, I think what you should do, change the slides by clicking on it the way you just did now. Yes, we can see that one. Thank you.
It is moved.
Yes, we are now on slide 3.
Okay.
So I think change slides so that you make sure that
So should I start?
No, just continue. We are with you.
Okay. So I was saying when debris has been formed from the phagocytosized bacteria, it needs to be cleared from the tissue. So immunoglobulins now are there to clear the bacteria and the debris. And then we are having the inflammation process, cell influx from capillaries. So full-thronged inflammatory response is now going to take place. The leukocytes have been activated and all the system are out fighting the invader. So the invader is being fought from all fronts. This is the peak or the climax of the inflammatory response. Okay? Are you seeing this slide? Hello?
We can see it.
Yes, we can.
You can see?
Yes.
Okay, that's fine. That's fine. Here is a diagrammatic illustration of what I was trying to explain or what I am explaining. Here we do have got an exogenous stimuli to an inflammatory process. You can have this thing is pricking the skin. The skin has been damaged, but you can see that the skin is got normal size initially. Then you are going to see here that the pathogens which have invaded the broken skin. When that happens, we are going to have histamines and prostaglandins released. When these are released, you feel pain. When histamine and prostaglandins are released, you feel pain. What is the role of histamine and prostaglandins? They actually cause vasodilation of the capillaries. When the capillaries dilate, and it creates a permissive effect so that the leukocytes can actually move via the walls of the capillary into the extravascular space where there's inflammation. So when this process happens, you are having what we call the inflammatory exudate that is coming to bring leukocytes to fight off the invaders. So that's where you are going to say, on ultrasound, I am seeing perisplenic collection or some fluid around the inflamed region. Why does that happen? It happens because we are having leukocytes which are transferred from the capillary into the region of inflammation, to contain or to fight off that infection. At the same time, histamine in prostaglandin production, it causes pain. It causes pain. So when you see that the patient is having fluid around the target organ or some effusion, at the same time is feeling pain, you are going to say, I've seen a first cardinal sign of inflammation. So when that happens, the leukocytes have come to the inflamed site. You come here. We are having the leukocytes and the blood clotting elements from the red blood cells. They are also coming in to repair the damaged tissue. So now when these red blood cells and the leukocytes are then in the extravascular space, the inflamed side, the skin starts to swell. You see the skin, the size of the skin and this side, this is swelling. So on ultrasound scan, how does it appear? You are going to say that my target organ is swollen, it is enlarged in size. So on an inflammatory process, you are expecting with the time that the tissue, the target tissue is going to increase in size or it's going to swell. So the capillaries dilate, then clotting begins. Clotting mechanism are here to try to block or to block external pathogens from entering. So they try to close the opening. So we come here because our leukocytes have now entered the injured tissue. Then the phagocytic leukocyte is going to start to act. What happens to these phagocytic leukocytes? They actually try to engulf the bacteria. In this state, you see that the capillaries are dilated because there is increased movement of blood towards that place. When it was the surface of the skin, in this state, you are going to see that there's going to be erythema, which is the redness of the skin is now presenting. On color Doppler, you see increased perfusion of the target organ or tissue. So the tissue is now inflamed, it is increased in size, swollen, at the same time, it becomes edematous. You can actually see some effusion around the target organ or tissue. I'm going to illustrate to you how it all looks like in actual ultrasound images below. So here is the last slide. The phagocytes, they're trying to consume pathogens in cell debris. So this is an ongoing inflammatory response when the phagocytes are trying to engulf the pathogens. So what basically happens with an inflammatory process is either it resolves in acute stages or it doesn't resolve. It can actually persist into chronic stages. So I'm going to explain as we go. Are you seeing the next slide?
Yes,
Okay.
we can proceed.
An elaboration of what I was talking about. You have got intertissue. After an inflammatory process, when the tissue is broken, bacteria invade the tissue. In response, cytokines and histamine are released that cause capillaries to dilate and become leaky, and that attract leukocytes. So dilatation of the vascular space is the one that I was talking about, that it causes one hyperperfusion, which is hyperemia. At the same time, because extracellular fluid or inflammatory exudate is going to target tissue, the target tissue, it actually swells or enlarges in size, and then tissue repair proteins and other substances seep through the leaky capillaries into the infected site. So the body is responding to the stimuli. So it tries to replenish or to repair itself. So this actually also takes place in an inflammatory process. So here we essentially have leukocytes also linked to the capillaries, phagocytes, the bacteria. I explained this earlier. So going down, okay, this is another diagram that is still trying to explain the inflammatory response. So the first thing that we have is the injury that can, which I have explained, that can actually be caused by an endogenous or exogenous stimuli, infection, infarction, tumor, stress, toxins, viral or chronic infection, or autoimmune disease or persistent injury can also act as stimuli to the inflammatory response. So we do have got two subsets or types of an inflammatory response or inflammation types, which is the acute phase and the chronic phase. In acute phases, that is where I said you see the vascular changes that are associated with the dilation of the vessels, then movement of the leukocytes or the inflammatory exudate into the extravascular space, which is associated with increase in size of the target organ, increase in perfusion. Then you also the neutrophil recruitment in mediators. These are the agents which are going to fight off the infection. Okay, so when this happens, because of the action of histamine and the action of the swelling, you experience pain. Okay, so an acute inflammatory process can actually progress into a chronic stage. When it progresses into a chronic stage, we can actually find or the process of angiogenesis can start to take place. The vessels which were there initially might actually be damaged by the external stimuli. When they are damaged, you can have collaterals or other types of blood vessels which are going to be insta-bleed as a mechanism to counter for the injury that is taking place. So angiogenesis can take place in the chronic stages. Then you can have mononuclear cell infiltrate in fibrosis. So in the chronic stages, actually, that's where you can find tissue is trying to heal. You can see the keloids on your skin. At the same time, tissue can start to show signs of fibrosis. So there are two things that can happen when tissue is inflamed. It's either it resolves in the acute phase or it continues to the chronic stage. It can either resolve in the chronic stage or it can actually persist. When tissue resolves in the acute phase, there's going to be clearance of injury stimuli, clearance of the mediators, and the acute inflammatory cells, replacement of injured cells, and back to normal. So when someone is inflamed and then delays to come for an ultrasound scan, then that's where they can come to the department. You're going to say your kidneys are appearing very normal, your appendix is appearing very normal, your pancreas is very normal. It is because the stimulus is actually resolved. So the tissue goes back to normal size, it goes back to normal perfusion. You are no longer seeing hyperperfusion. The tissue is resolved. An acute inflammatory process can actually persist in chronic stages. Then what you're going to see, you're going to have fibrosis and loss of function because the blood supply, the target organ has been compromised. What this can happen is the tissue can actually show signs of death. Infection can set in. At the same time, you are going to have necrosis of the target tissue and loss of function. That's where you are going to say the kidneys or the pancreas is now shrunk. So it's going to shrink in size because it's now dead. In this stage, that's where you can see a hyperechoic organ reduce size. At the same time, you might not see fusion on Doppler. It is because the tissue is now died. It has persisted into the chronic stages of inflammation. So this is again an illustration of the inflammatory process. Okay, as I was saying, the first thing that takes place is an injury to the target cell. So when tissue is injured, I want you to listen here very carefully. I want you to listen here very carefully. This is a tissue that is injured. When acute inflammation takes place, you can actually have an abscess formation. As I was saying, that the debris that collects, that is supposed to be destroyed by the neutrophils, can actually collect as abscess. That's why you find that some of the inflammatory process or responses, they are associated with abscess formation. That's where you can say, I am seeing an abscess, the periappendiceal abscess. It is because it's a response to the inflammatory process. The debris is now collecting as an abscess. This abscess can actually rupture or it can burst. Then you find an ulcer that is going to develop due to an inflammatory response. when an ulcer develops, there can be a fistula that you can see. When a fistula develops, is either or a sinus, a fistula or a sinus can then develop. What then happens is you can actually have exudation of free fluid, then it presents around the target or the damaged tissue as serous exudate. Here is water exudate, which can indicate early inflammation. That when you're holding a probe, you see this peri-organ collection or effusion. When you see hyperperfusion around the target area, this is because of the serous exudate. So if you see fluid around a target organ, very an acute phase of the inflammatory process. The fluid the exudate that you can find can actually have fibrinous exudate, or it can have thick fibrin-like strands or structures. So you can find thick clotted exudate indicates more advanced inflammation. So when you are having this fibrinous exudate, that's where you can say, I am seeing a collection that has got some septations. It is because of fibrinous exudate. But still, you can actually link it or relate it to the inflammatory process when you are fulfilling the demands of the other 5 cardinal signs of inflammation. So this you are seeing in connection to pain. So you are going to link that to an inflammatory response. So basically, when you're holding a probe, these are the markers, or these are the things that you'll be looking at. Look at serous exudate, peri-organ collection, look at fibrinous exudate. You can see actually some clots or some fibrin strands inside the target tissue. Pyrulent exudate can also happen. You can see pus collection indicates bacterial infection. So as I was saying, when you see an abscess associated with an inflammatory process, you can then query a bacterial infection that is taking place. So this is the endogenous stimuli that is causing the inflammatory process, or actually after the tissue injury, bacteria has entered, then you see pus collecting around the target area. It can actually be in the form of an abscess. So lastly, we can have hemorrhagic exudate. You can actually, because the tissue has been inflamed or injured, so you can see blood around the target issue. So you can actually expect to see a collection of blood around the inflamed organ. This you know the sonographic appearance of blood. Actually, it can have fibrin strands. At the same time, it can have some echogenic particles that you can think of. At the same time, there can be hematoma formation around the target organ or the inflamed organ. So let me come here. Okay, so here, these are just a pictorial demonstration of the inflammatory process. So as I was saying before, when you have an inflamed organ, taking for instance the pancreas. So this is an example of an acute pancreatitis case. The first cardinal sign that I was talking about is an increase in the blood flow to the target area. At the same time, the capillaries are going to open. When they open, the organ is going to be edemacious. The organ is going to be edemacious because of the inflammatory exudate. So my organ is going to be thick, edemacious. How do you see this acute inflammatory process using your scan? This was because of the edema, because of the inflammatory exudate. You are going to see it becomes more hypoechoic. So a hyperechoic organ, it shows, or it's an indicator of an acute stage of inflammation, because when fluid leaks from the capillary space into the extra vascular space, it actually causes tissue inflammation. Oh, sorry, it causes tissue swelling that you see is an inflamed edemacious organ. So be it the kidney. An inflamed kidney, you see, it's edemacious. It appears more hypoechoic. At the same time, it's increased in size. On the O, you can also see hyperperfusion. Because more blood is coming into the target area, it is going to be hyperperfused. On compression, what happens? You are going to see pain. So these are the indicators or the signs of inflammation. Let me proceed like this. Here is a model. Here is a model pancreas that I'm taking as an example. This is a normal pancreas. You can see the normal pancreatic head, which measures something like 45 millimeters. Then you can see this is my pancreatic neck, which can actually measure something like 10 millimeters or so. Then you do have the tail that can measure up to about 25 or 20 millimeters, just like this. So if you analyze, or if you look carefully at this pancreas, here is the landmark that you are going to use, which is the splenic vein. So the splenic vein here is here. Then you can see the aorta is somewhere here. The spleen, if you look at the pancreas closely, let's look at the region around the pancreas. You can see it's clear. There is no collection here. We cannot see collection around. You cannot see collection. There's no collection here. Meaning to say, it's unlikely that we are having an inflammatory process, because there is no exudate that can collect as pancreatic effusion around here. So there's nothing of that sort. If you look at the pancreas again, if you can see at the right lobe of the liver, they are of almost comparable ecotexture with the liver. It's not looking significantly hypoechoic. We expect in acute stages that this pancreas becomes more hypoechoic because of the inflammatory exudate. But in this case, it's comparable to the parenchyma of the liver, meaning to say we don't have signs of inflammation. When it is in the chronic stages, we expect to see shrinkage of this pancreas. We expect shrinkage. When it shrinks, it undergoes fibrosis, then our pancreas is expected to be more hyperechoic, and then you can actually expect to see maybe some stones that is going to form, some calculi, some stones that are going to chip in, because there is going to be loss of function of the pancreas in acute stages. So going down here is another example of an inflamed pancreas. So if you look closely at this type of a pancreas, let us look at the peri-organ region around the target organ. This is our pancreas. But if you look closely, you can see that there's some effusion. There's an effusion around the pancreas. So what is causing this effusion is because the capillaries have actually dilated, and then we are having a situation whereby fluid is actually moving into the extravascular space. This is the fluid that is collecting around here. So this is now an indicator of an inflammatory process. But you don't rush to say, because I have seen peri-organ collection, so it's automatically an inflammatory process. This could actually be, you could actually see fluid around an organ due to ascites, maybe due to liver conditions, due to the heart problems as well that can cause ascites. So you marry this effusion to the other 5 cardinal signs of inflammation. If you compress this, is the patient feeling pain? Is the patient in pain? Then you also measure the pancreatic head, the pancreatic neck, the pancreatic tail to see if there is swelling of the target organ. As I said, with an inflammatory process, you will expect swelling of the organ. So if you see that is happening, you then start to think about an inflamed pancreas. It's the same with this. This pancreas is actually very thickened pancreas. You can see there's a bit of some edema around there, and the pancreas on its own is actually very thick if you look at it by inspection, and edemaceous. So this is pancreatic effusion you are seeing here. The same with this type of a diagram again. This is an edemaceous pancreas. So the same applies to all organs when they're inflamed, be it the appendix or be it the kidneys. You actually see edemaceous organ, then it will become a bit hypoechoic. So let me go down like this. Okay. So this slide is basically showing the chronic stage of inflammation. There is sustained injury to the target organ. So now what happens, you can actually see a dilated pancreatic duct because the muscles that makes up the pancreas, they've lost their tone. So they can no longer contract or relax in the usual manner. So you see the duct here is going to be dilated. Then it becomes more bright. It's now it's undergoing fibrosis. So here is a stage of reaching a stage of functional lysia. This is becoming permanent. Permanent dysfunction of the organ because of sustained injury. So the blood supply is now getting compromised, and then you can see the outline of the spleen is now very irregular. It's now shrinking. It's now shrinking. It's now shrinking. So if you measure the pancreatic head size, the neck and the tail, it is supposed to, or we expect it to be below the normal size because the organ is now undergoing necrosis. So when there are your kidneys, the kidneys are now no longer functioning. We talk about the chronic renal failure, and then it can be associated with calcification or stone formation. So here are examples of chronic inflammation. In this case, I'm also using the pancreas as an example, but this does not apply only to the pancreas. It applies to all organs, target organs that are inflamed. So basically, with an inflamed pancreas, this is a stage of necrosis. The tissue is now undergone necrosis. You can see this formation of stones. So you can see some stones that are setting in. You can see the stones there. You can see stone there. The spleen on its own is actually now shrunken. It's now shrunken. You see, smaller in size. It's now very much smaller in size with calcification. So when you see calcifications in an organ is also shrinking with associated pain, you expect that it is a chronic stage. A chronic stage. You differentiate a chronic stage from an acute stage because in an acute stage, the capillaries are still functioning. They are still bringing blood to the target organ. You see hyperemia, but when the tissue is dead now, you don't see perfusion, or the perfusion might be segmental. It actually supplies other segments. Other segments are undergoing a permanent death. So here in these areas where you see the permanent calcifications, we don't expect to see flow in these areas. So that is how we are differentiating an acute stage of inflammation with a chronic stage of inflammation. In this instance, you cannot see peri-organ collection, effusion, sorry. Why? Because the normal process whereby fluid is moving into the peri-organ space is no longer taking place because the blood supply has been compromised. But in acute stages, in chronic stages, sorry, what then happens when it is a spleen, for instance, you can actually find fluid that is produced, the pancreatic cells which are produced by the pancreas, they can actually collect outside the pancreas. So you can actually see here, maybe at the tail or at the head, you can see a collection that we call a pancreatic pseudocyst. So you can see pancreatic pseudocyst. It means they are a sign that the pancreas is no longer functioning. So the cells that are supposed to be produced, they're now collecting as effusion in the region around the pancreas. So we are talking about the last cardinal sign, which is function lysia. The organ has lost its function permanently, so it's undergoing necrosis. We expect expect the same with an acute inflammation of the appendix. We expect the same with acute inflammation of the kidneys. So any organ, when you're doing a scan, those are the markers, or these are the things that you're looking at. You're looking at what's the behavior of the organ in terms when you put color Doppler. Is it still perfused, or it has undergone a permanent state of death, which is necrosis? So when a tissue dies, it's no longer growing in size, it's shrinking. So it's atrophying. So this is a sign of a chronic inflammation. The same applies to this pancreas again. I'm using a pancreas as an example. You can see the main pancreatic duct here is dilated. It means the pancreas has lost its normal tone and it's actually shrinking size. It appears big here, but in fact, it's actually a picture in zoom mode. So you can see deep calcium deposits here. You can see the deposits here, the deposits. These are indicators or markers of an inflammatory process in its chronic stages. So when you are holding your probe, you look at the organ relating the 5 cardinal signs. So when you see an organ that is undergoing necrosis or infunction, we think about the 5th cardinal sign of inflammation, which is function leasia, loss of function. So my pancreas now lost function. You only think of a chronic stage. This happens in the chronic stage. In the initial acute stage, we expect this to be edemacious, more hypoechoic, hyperperfused with hyperemia. Okay, this is another example of a slide that is demonstrating a chronic pancreatitis. As I was saying, in chronic stages, we expect that the target organ, if it has failed to resolve or to heal, it is going to die permanently. So you see, it's very bright. My pancreas is now very bright. It has lost its outline, its normal contour. So you can see it's very much irregular. At the same time, we say it's now fibrosed. Though there are no calcifications here, but this brightness, it is a sign of extensive global fibrosis of the pancreas. So this pancreas has lost its function. This is a sign of chronic pancreatitis because the pancreas is now undergone the process of function leasia. It has lost its function. So when you're holding a probe, you're not just holding the probe nicodemously or just like a gentleman. You are looking at the 5 cardinal signs according to Cornelius Celsius, the 5 cardinal signs of inflammation. That's what we are looking at. And then analyze the target area. Is it undergoing necrosis? Is it dying? To show that it's a chronic injury. Then you can see, how do you see that? It appears shrunken the organ, fibrotic, hyperperfused, hyperechoic, sorry, or on ultrasound scan. Shrunk, hyperechoic. At the same time, when you put a Doppler flow here, you don't see flow on color Doppler. Okay, I'm still trying to explain or to make meaning of what actually can happen with chronic inflammation. Okay, with chronic inflammation, this is what we can expect. One, as I explained before, you see peri-organ effusion, like peripancreatic effusion, free fluid around the target organ. If it is a pancreas, like in this case, you see an effusion or some fluid around the target organ. So this, you see it basically in the phase before or just after inflammation. Then in chronic stages, what you see, you can see because of loss of function of the pancreas, you are going to see a pancreatic pseudocyst can actually start to develop. So that's why you are going to say, I'm seeing a pancreatic pseudocyst. This basically happens in chronic stages of inflammation. You can also see the target tissue going necrosis. As I said, this guys does not apply only to the pancreas, it applies to all organs like the kidneys, like your appendix. So if you see a sign of necrosis, we think of chronic pancreatitis. So basically, I was explaining about this. Okay, let me go to this slide. So on ultrasound scan, you can see here, this is my pancreas. So this pancreas, you can see, is very much ecopenic. It's hyperechoic. You can see an ecopenic pancreas here. And then if you look between the pancreas, you can see a very much dilated main pancreatic duct here. But here at the pancreatic tail, you can see that there is this cystic structure here with ill-defined margins, but which is lobulated like this. This is a typical type of what is called a pancreatic pseudocyst. The pancreas has lost its normal tone and function. Then you can see the collection of this fluid here, of which this fluid is supposed to be produced, then it moves via the main pancreatic duct, just like that. Then you see this is a typical example of pancreatic pseudocyst. So it can be giant like this. You see, this is a pancreatic head pseudocyst, which is adjacent to the left lobe of the liver. So let me go to the okay. Are we still together?
Yes, we are here, Mr. Chitumba.
Okay. So
they have muted the mic. Yeah.
Let me go back to the first slide. So basically, this is the inflammatory response. This is the inflammatory process. So the inflammatory process, in a nutshell or in short, is one of the critical areas that a sonographer, a radiologist has to master or to know, because it gives you answers when you're doing an ultrasound scan to then say or to quantify or to qualify an inflammatory process vis-a-vis a non-inflammatory process. So the thing that I want you guys to master, or the thing that is going to make you a good master when you are doing ultrasound scan, is to know the cardinal signs of inflammation. So when you're holding your probe, do not hold your probe without having in mind the 5 cardinal signs of inflammation. Know about them, think about them, look at them. Look at redness, rubor. You look at hyperperfusion of the target organ on color Doppler. If you don't see hyperperfusion, otherwise, see it, color, the blood supply is increased, the target issue, the vessels, they are now dilated. So we expect to see that hyperactivity or hypervascularity when it's the right kidney that is inflamed. You compare it to the left to see if the perfusion is of comparable or they're comparable or not. So look at swelling within the framework of an acute inflammatory response. We expect to see swelling of the target organ that manifests as an increase in size of the target organ because of the inflammatory exudate. We expect to see the target organ, it can be hypoperfused. But there are exceptions to these rules or to these cardinal signs. At the inception or just after an inflammatory process happens, you might need some time to see the inflammatory response. So the target organ might appear very normal. You can see that the patient is not having acute pancreatitis because it is at the inception, at the beginning of the process. So the organ might appear normal. So you give chance or give some time to the patient to say, maybe the patient come back for a scan tomorrow, because we need to see the movement or the stages of inflammation as they are setting in. At the same time, pain is something that you have to look for. Do not just rush to say that an organ is inflamed without the manifestation of pain. This you can do by compression. Use gentle compression using your transducer. Do not overcompress the target area because you might actually cause target rupture, organ rupture. Like your appendix might actually rupture. So just be gentle and see how it behaves. Also, ask the patient maybe to localize the pain, the whole way they are feeling the pain. Then you see if there is tenderness that is consistent with a cardinal sign of inflammation, according to Cornelius. So the last aspect that you have to take note of is the loss of function that I was talking about. Look at the nature or the characteristic or the morphology of the target organ to see, is it still functioning? How do you assess functionality of the organ? You can say it's perfused, it's well perfused, it's not showing regional or segmental or global hyperechogenicity or deposition of calcifications or areas of fibrosis that are underperfused or unperfused, to show that there's actually sustained loss of function. on the target area. So in a nutshell, these 5 cardinal signs are the verses in the scriptures of the Bible that a sonographer or a radiologist has to read day and night. When you are doing your scans, have them in mind. Do not scan Nicodemously without knowing the 5 cardinal signs of inflammation. So if you made the pathophysiology and the sonographic appearance, you will never miss an inflammatory process because you are taking it stepwise from the cardinal signs. So you can actually reject or accept an inflammatory response when you marry the 5 cardinal signs to the presenting sonographic signs or that you're seeing on ultrasound scan. I have done more than enough of talking. I also need you guys to chip in and do the talking as well, so that we are at par, or those who need clarification or those who've got questions, you can go ahead and then ask. I think this marks the end of my short presentation.
Thank you so much, Mr. Chitumba, for that wonderful presentation. I want to believe that there are questions, contributions, as well as additions. From my side, I'm really grateful that you brought it up, because I think for every sonographer, you take the role of a clinician. So if you hold a probe and you're not sure of what is happening, it's quite deadly. We've been taught about the 2 segments or the 2 types of inflammation, which is the acute and the chronic. I think it is very important that we always pick the first, which is the acute, in the event that you may even forget what the chronic is all about. From my notes that I've captured from what Mr. Chitumba has said, in the acute stage, actually in either of the acute or chronic, there are 2 things that are very cardinal to that process to take place. The first one is the vascular changes. The second one are the cellular events. So with the vascular changes, now we are made to be reminded that when we have vessels, the arteries have receptors on them. I think these things we were taught that there are receptors for the nitrous oxide, for the prostaglandins, for the histamines. So I was actually thinking of an accident scene. I was thinking about the acute response in terms of the inflammation. Where there's been an accident, if the road was congested, the first thing that would do is to clear the road so that whoever is bringing help to the injured has a way to get into that area. The second thing is that we relate it to the vasodilation of the vessels. Then there's the increased permeability. But with increased permeability comes the issue of the proteins that would then see as exudate. So at times when we are faced with information like, let's take them into real life scenarios and then see how these things can make sense to us. So with that short comment on my short notes that I took, I'd like to open it up to everyone. In case you have a question or a contribution, you may raise your hand and you can unmute the microphones. Thank you so much.
Okay, I can see there are 2 hands up.
Yes, I think you can. Yes, I can't see. Maybe you can just let them speak. Yeah.
Okay, Ms. Masunda.
Yes, it was a very nice presentation, except for in the beginning, there was some confusion about the slideshow. Otherwise, it was very good. And I hope we continue these sort of things. Thank you.
Thank you so much. You're welcome. Mr. Paul Makondo.
Hi, Chitumba.
How are you, sir?
All right, how are you doing? Thank you so much for your presentation. Thank you so much for a good presentation, and we are prepared. I've got a question and just a question at the same time. The question, I was happy to see. I'm happy to see the pancreas, looking at the stage where you can find even some calcifications. How long can that process take? in my little practice, I think I've never seen that, but how long can it take? And in your practice, how many have you met so far? Then,
in my practice, I've seen, hello?
Yes.
In my practice, I have seen quite a number. Those who are in the ultrasound universal group, you can see last week I posted one that was having a pancreatic pseudocyst. Did you see that one?
Yeah, I mean, looking at calcification pseudocysts are quite okay. My question is on the where you have got calcifications in the pancreas.
I've seen quite a number of the calcifications. Unfortunately, what happens with the pancreas when it calcifies, it becomes so small to an extent that most people, they actually miss it. So you can actually miss a pancreas, then it can actually mange, or you think maybe it's part of the bowel or part of the duodenum that is around that region. So when it's calcified, most people, they don't assess it that much. So it is good for you or prudent for you when you're doing every ultrasound scan to actually have the patient take some glasses of water so that you fill the stomach to act as a window so that you actually delineate and then look at the calcifications. When you are in part of the groups where I'm sharing cases, I will send or I will share with you the calcifications, the fresh calcifications that I will be meeting as I do the practice. Maybe you can appreciate those.
Okay, second question.
Yes, can go ahead.
You have talked much about pancreatic fluid collection, but in essence, whereby sometimes from my practice, I've seen it sometimes becomes quite huge. Are there some characteristic features which can help you isolate that fluid which is caused by pancreatitis or aside caused by pancreatitis from others? Are there some characteristics?
The characteristic of the free fluid around the target organ?
No, it acts in the peritoneal cavity.
In the what? In the peritoneum?
Yes.
Come again?
Yes, not just in the. What I mean, not just
question.
Okay, I'm saying
you are asking about the. Go ahead.
Are you there? Yes.
Yeah, I'm here.
I'm saying apart from the pancreatic fluid collection, there are times when you have got a good amount of ascites, fluid collection in the peritoneal cavity resulting from pancreatitis.
Yes.
The question is, how do you differentiate? How do you differentiate that fluid from other sources of ascites? Just to associate, this is actually from pancreas.
I think I was very clear from the inception. I did say that when you are looking at an inflammatory process, it's a holistic approach. You have to look at the 5 cardinal signs and you marry them to the presenting sign that you are seeing. So the first thing that you're supposed to be looking at here, I talk about redness of the skin, I talk about the swelling, the pain, then the functional lesions I was talking about. So the thing is, when you localize the pain, where is the pain? Then the patient is going to say, I am having an epigastric pain. Then you try to compress it using a probe. Then you localize the pain. Then the pain is not felt elsewhere. It doesn't mean that when one organ is inflamed, other organs are not inflamed as well. An infection can actually spread. It can actually infect the pancreas. Then you can have peritonitis as well. So they can have pain almost everywhere. It's very rare for you to have only an inflamed pancreas. Then it's sending ascites, let's say gross ascites to the body. It's very rare. It doesn't happen like that. Basically, the processes or the pathologies that normally sends ascites like that are malignant. The malignant tumors, then the liver conditions or the heart problems, they're the ones that can actually cause a patient to have gross ascites. I've never come across a case whereby a patient with acute pancreatitis having a gross ascites, or a patient with acute appendicitis having gross ascites. Basically, the fluid that we're seeing, it can actually be marginal, just around the organ. It's just a bit of it that you see there to show that the inflammatory process is localized. As I said before, that the term loss of function I was talking about, your system tries to localize the pain so that it doesn't spread elsewhere. So the inflammatory response is actually regional. It takes place at the target area. So the infection and the inflammatory exudate that comes with the inflammation is localized. It normally doesn't go to affect other areas. If it does, then you can have a process like someone is having peritonitis that is affecting the rest of the abdomen. Did I answer you, or do you have something else to ask? Hello,
Mr. Paul.
Thank you so much for that information.
Yeah, I think just to add on to what Mr. Chitumba has said, Paul, concerning that question, if you look at the vascular events has to do with the vascular supply as well as the size of the organ that is involved. So most of, like say the pancreas, the kidneys, and what these will be small organs. And then what is the main thing that would affect the collection that would be seen around the organ? This is dependent on the difference between the hydrostatic and the osmotic pressure, which is very cardinal. So if you're dealing with small vessels, most likely you would not see a global collection in the abdomen or in the peritoneum. So that won't be the case. And let us not forget that whatever it is that we might be seeing, that's the reason why you would do maybe a pleural tab or an acetic tap, and then from there do cytology and then find out what could be the causative agent. But like Chitumba has said, it's rare. Like actually, personally, I've never encountered that in my practice to find, because of pancreatitis, you have this severe collection. Then concerning your question on the chronic pancreatitis seeing calcifications, I think I've seen a number, maybe 15, 20. But generally, for you to have calcifications, that takes a number of years, but it's not really defined whether it's 3 years or 4 years, but basically it would depend on a particular individual, what has been done, because in some patients, they may have an infection, it's treated, they have an inflammation, it's treated, others it's left untreated. So there are those variations, but a general rule is that it takes a number of years before your acute pancreatitis develops to chronic pancreatitis, and then you eventually having, like all those diffuse calcifications. I can see a hand, Mr. Cuthbert. May you ask your question? Thank you.
Thank you so much, Mr. Chitumba. That was a great presentation, quite a good lesson for us sonographers. I've got a question and a contribution. My first contribution is that... hello?
Yes, proceed.
I think I can hear you. Thank you so much.
Yeah, my first contribution is that we also have to be aware of power Doppler in this acute and chronic inflammation. Power Doppler plays a very big role. I think most of us sonographers, we avoid that button on the machine, but if you have a dedicated machine with power Doppler, make use of it. However, power Doppler compared to color Doppler, power Doppler has got a clear advantage in that it's able to detect hyperemia where there is less flow of blood compared to color Doppler, which may not pick blood flow where there is less blood flow. So color and power Doppler, those are two important things that may also help, particularly in PID. They can be so helpful. Literature has mentioned that, so we can make use of it. Secondly, I want your comment, Mr. Chitumba, on the what is your comment on the relationship between the acute appendicitis and kidney echogenicity in pediatrics? Literature has said that when there is acute appendicitis, the echogenicity of the kidneys tends to also increase in echogenicity. May you kindly give a comment on that? Thank you.
I think you brought the literature. I am not quite sure about the relationship between the two, but as you have said, I think I will look into that literature, or you can share the literature as you said. I have never come across the interrelationship between the two or the interlink between the two. But I am very much willing to get more or to learn more about it.
Okay, no, thank you. Thank you so much. Thank you so much. Thank you so much, sir.
You're welcome.
Thank you.
You're welcome. Mr. Geshlari.
Yeah,
Hello.
thank you so much. Yes, I'm here.
Okay. You can go
thank
ahead.
you so much. Thank you so much for the wonderful presentation, sir. Really learned a lot. My question is, for example, if the patient has got appendicitis and it ruptures, you see fluid around it. So my question is, when can the presence of fluid, or what are the indicators of peritonitis in such a case?
Okay, peritonitis is a different condition altogether from acute appendicitis. As I said, that there are different stimuli that cause an inflammatory process. They can be endogenous causes. They can be exogenous causes. When I talk about the endogenous causes, I'm talking about that stimulus that is coming from within the body itself. And I'm talking about exogenous coming from elsewhere. So there can be bacteria that can be coming from outside. Then it can actually affect other organs, and it can actually affect the peritoneum as well. So in that regard, the difference between peritonitis and appendicitis is we are talking in terms of the localization. When we are talking about exclusively about acute appendicitis in the setting without peritonitis, we are talking about localized inflammation. But when there is a stimulus that is causing the inflammation to spread, like cases of tuberculosis, you can have infection that is actually global, that is affecting mouth organ at the same time. So in those cases now, it's no longer a single organ infection. This is now global infection, of which peritonitis, because it's affecting the peritoneum, we are likely to see peritoneal collection then that presents as your abdominal ascites stretching everywhere. Unlike your acute appendicitis, where the fluid that I was talking about is just at times mild, just around the organ. You can just see a line of a hypoechoic region or outline around the target organ to show that it's an inflammatory process. But you don't then just jump to the mass to say, because I've seen some collection around the organ, so it's automatically an inflammatory process. It might not be. It might actually be a bleeding from that organ. That is not actually an inflammatory process. Like when you're doing when we're doing our scan to rule out for organ damage post trauma of after an accident, you actually are looking at when you're doing the fast, you're looking at the peri-organ collection. It doesn't necessarily imply an inflammatory process. So fluid on its own around a target organ does not imply peritonitis. When you have got ovaries or the malignance, you can actually see an effusion of fluid around it. It doesn't imply an inflammatory process. An inflammatory process has to be married by the other cardinal signs, as I have highlighted and alluded to. Okay, have I answered you?
Thank you so much, sir.
Welcome.
Yeah, just a quick contribution, I think, from the question that was raised by Cuthbert, because I think when we look at the first aspect, and I think this is where what you've presented, Mr. Chitumba, is very cardinal. The first aspect that you told us is the vascular response. So there's the vascular response, then there's the cell response. So dealing with the vascular response, yes, the perfusion may be, say, to a specific organ. In this case, the injury would be on the appendix. But the response in terms of the increased perfusion may not be particularly unilateral dealing with the organ. So I suspect, I mean, this is just theory based on what I've learned and what you also shared, is that the kidneys might suffer the consequence of that increased perfusion to where there's been an appendicitis. So probably the cellular changes, the fluid pressures in the kidneys would then lead to a change in terms of their echogenicity, but not necessarily a damage to the kidneys or a dysfunction. I think this would be just a response because there's a global response that the body is trying to deal with a particular, inflammatory process that is happening. But I think it would be nice to see the literature that is there. Probably Mr. Cuthbert will share with us so that we may actually dig more into it and get, I think, a better understanding. But from my little understanding based on just inflammatory response, I think it would be just a consequence of probably vascularity, because it would not be totally regional to the appendix, but the kidneys might actually be involved as well. And probably we might actually see that maybe even the pancreas might even show similar characteristics. Thank you. Precious.
Thank you for the insight, Mr. David. Precious.
Yes.
Sister Precious, welcome. Sister Precious, are you there? Hello?
I think she's not there.
The hand was up by mistake.
Cuthbert, your hand is up.
No, sorry. I think you've clarified one or two things, but I think this has been bothering me for some time, and I thought maybe in relation with inflammatory responses, because the literature has been so clear to say it's particularly in children and in the absence of renal, hepatic diseases. The increased echogenicity in the cortical echogenicity, renal cortical echogenicity has been a reliable sign in the diagnosis of acute appendicitis. So I thought maybe we could dissect it, but we still have to reason together and read it. Otherwise, this has been bothering me for some time. Thank you so much.
Thank you.
All right.
Okay. Thank you, Mr. Cuthbert.
Yes, sir.
All right. Thank you, Mr. Chitumba. Yes, I'm here. Thank you very much for a very informative presentation. My question is on nephropathy. What is the role of ultrasound in the diagnosis of nephritis? And can it also be used as a standard in classifying the types of nephritis, like glomerulonephritis or pyelonephritis? Thank you. Yes. Did you hear my question?
Yes, I have heard you talking about nephropathy.
Yes. I wanted to understand if ultrasound has got a role in the diagnosis of nephritis, and also if it has, there are standards in classifying the types of nephritis, e.g. glomerulonephritis and pyelonephritis.
They are not much. There's not much difference in terms of classifying using ultrasound. This now poses as the major limitation of ultrasound at times, because as a human being using your eyesight or your judgment, you might actually mistake one for the other. So it is very difficult at times for you to make that distinction using ultrasound. But the biggest thing, or the biggest advantage that we have, is basically the management of the inflammatory process might be the same. So at the end, you might get away with the murder, or with actually trying to have a headache, or on differentiating the two. But basically, when you understand that we are dealing with a case of inflammation, I think you'll be good using ultrasound. Ultrasound is good, but it also got its own limitations, where you might end up lying, because you are trying to do rocket science. Hello?
Thank you very much.
Welcome.
Any other questions from the background, contributions?
Yes, Mr. David.
Yes, you may go ahead.
I wanted just to thank Mr. Chitumba for the wonderful presentation as well, and also ask from the sequencing of the inflammatory process that he has highlighted. Can we therefore hypothesize that there are some organs that are more prone to chronic, more vulnerable to chronic inflammation than others? If that's the case, what would be the underlying factors for that?
Hello, Ms. Laxon.
Yes, sir.
Thank you for the question. Thank you for the question. But your question is one of the most difficult questions I have ever answered in my entire life. But based on my judgment as a human being using my common senses, I would suspect that susceptibility of inflammation is dependent, one, on geographical location, two, on the causative agents or the triggers that is causing the inflammatory process. There are places like when we're dealing with if you remember Mr. Nandala's cases where he was sharing those schistosomiasis cases which are prevalent in Tanzania, you can see that the infection of the kidneys and the blood is so rife in that region because of the prevalence of schistosomiasis. The same might not apply in a case like in Zimbabwe. So I would suspect that inflammatory process or agents, the causative agents, they would some bearing maybe on the geographic location. At the same time, maybe on the types of diets. There are so many factors that are interwoven. But however, I also suspect that the location of the organ might have an effect. Like if you see those organs that are involved in the urinary system, because they're persistently working, trying to clear that debt in the process, they are prone to infection. Also, when we're talking about the appendix, because of its location or the nature of its anatomy, it's also prone to infection, especially when someone is having those sugary diets and whatnot ever. So practically, I don't think we can say that there's an organ that is more prone to get an inflammatory process than another. It all depends on the activities of the individual involved or the lifestyle of the individual involved, the geographical location of that place. I think that is my contribution.
All right. Thank you,
Mr. Laxon.
Yes, sir.
Welcome.
Thank you. Though my other aspect of the question, the other aspect of the question really
you can
was.
Ask.
Hello.
Yes, you can go ahead.
I can hear you.
Yeah.
I can hear you.
Okay. The other aspect of the question was really concerned with the why would it be that it is easy for some organs to graduate easily to chronic inflammation. For example, where you know, I've never seen, for example, an ovary having inflammation that has culminated in calcification. I don't know how many have seen them before, but for other organs, you'd find it would be easier for them to culminate into such a state of fibrosis where they would end up in that situation. Whilst others,
okay, I get you now. Okay, let me try to answer that one. I think that one, it depends. It's a function of the blood supply of the target organ. Let's take, for instance, the liver. The liver is got a dual function from the portal system and the hepatic system. So basically what happens is when the hepatic system is compromised, the liver can still continue to function because of the portal system. So basically, it all depends on the perfusion of the target organ. So when the organ doesn't have much vessels that feed it, if one vessel that is feeding it is compromised, if there are no collaterals, that type of an organ, it actually shows signs of chronic inflammation more than a target organ that has got better perfusion, because it has got collaterals. In the event that this blood channel is blocked or is compromised, then the other collaterals can actually drain it. So in that case, the tissue with more collaterals or more vessels that is feeding it, or a diversity of vessels, it actually can sustain itself and resolve better than an organ maybe that has got a single artery and a single vein that is supplying it. Because when that vein is affected by the inflammatory process or is blocked during the inflammatory response, that organ is actually going to die, and it dies faster than an organ that has got multiple sources of perfusion.
Yeah,
Hello?
I think just a small addition. I think, Mr. Chitumba, you had rightly put it in your earlier statement concerning the issue of the function. If you look at the ovary, I think I would call it one of the organs whose function comes once a month. Then you look at the kidneys, whose job is actually every single minute. To balance the fluid, that has to be done every single second. To regulate blood pressure, it has to be done every single second. So depending on the number of functions that an organ performs, as well as the duration for that function to be done, I think that also plays a very critical role in, say some organs developing, maybe going into like chronic inflammation, and then having all the other features that we've talked about. So I think the function, of course, I'm not excluding the issue of vascularity. I think that one also plays a role, but the function, the number of functions, the time when these functions are required, I think that is really why probably we see that, I mean, we have a bulk of cases for, renal failure, unlike where you have issues to do with the ovaries that at some point post-menopausal, the function almost ceases. Thank you.
Wonderful. Thank you so much.
Okay. Is there any other question? Any contributions?
Sorry, curiosity,
yes.
out of curiosity, that is, I know that we picked the pancreas in this presentation, which was a good thing. I would have been happy also, just for the sake of curiosity, to look at the journey for the liver, for example, from the transitioning from acute hepatitis to chronic hepatitis, just trying to look at the processes that it undergoes and sonographically relate it so that as sonographers we are able to quickly differentiate between chronic and acute hepatitis, which is one of those hard things to do sometimes. Also, maybe touch a bit on the process of cirrhosis, cirrhosis liver and all that, so that we can quickly, maybe some of us get more detail on that.
Okay, so basically you would like to have another presentation.
Thank you for asking that. Mr. David.
Yes.
Mr. David.
Yes, sir.
I wanted to add to what Mr. Jokonya is asking. I think that can be done on the group. Like, let's say we see a case of acute hepatitis, we actually then going to digest and try to apply the 5 cardinal signs of inflammation. I think from there going forward, it will be easier for you to. I think we are going to apply what we've learned now to the actual practical aspect. Then we share the cases. Then we try to explain. In this case, we're suspecting acute pancreatitis or chronic pancreatitis because of 1, 2, 3, 4 reasons. Then marrying that to the inflammatory response, the 5 cardinal signs. So it can be done, but because of the constraints of time, we cannot then add all the organs on this presentation because it's limited in terms of time.
Yeah, I think maybe the fact that he has brought it up, my consideration was that maybe we give it a slot because I'll have to speak to the other presenter. Then if possible, I could get someone that could talk about it next week, Thursday, so that I think whilst the information concerning inflammation is still, hot, then we add on to the aspect of hepatic diseases as an extension of it. Probably, I think that one would be beneficial, but I'm also agreeable to what you've suggested, Mr. Chitumba, that on the group, if we have a case that is posted, then we break it down into stages and then relate to that. So I think that one we cannot exclude it, but I think it would also be beautiful because not everyone that joined us on this group is on the ultrasound group. So for the benefit of those that may not be with us on the ultrasound cases group, they may actually join us on this particular platform.
Thank you so much.
Yeah. So I think if there are no questions or contributions, you kindly allow me to thank Mr. Chitumba most earnestly for a very wonderful presentation that he's given to us. I will definitely upload this presentation onto our site on YouTube. Those that want to watch it again can go through it. And we are sorry that we had a few technical glitches. And like we've always said, it will get better with time. This is just the beginning. And from everyone else that joined us around the world, we are totally grateful that you've made it a point. And we are also open to those that are overseas. I think Masuda is in Pakistan. If you want to share anything via these presentations, please do get in touch with me, or you can get in touch with Mr. Chitumba. Then we shall do the needful in terms of scheduling you. So maybe in 30 seconds, if there's anyone else who would like to say something, after a minute, I will officially close this meeting. Thank you so much. Good evening, good morning, depending on your time zone.
Honorable Ikua, you can go ahead.
Thank you, Chitumba.
How are you,
so
sir?
much for a wonderful presentation. Thank you, David, for coordination. I just wanted to.
Thank you.
I just wanted to ask if we are in a position maybe to be tackling an organ like this time. We were talking about inflammatory processes, and we went and tackled the pancreas, and it was really nicely outlined, and I loved it. If we could also take the liver, and then maybe the other week we could take the kidney, because these are some of the organs which every now and then would come to ultrasound to be checked. Many people would just want to throw a diagnosis like, okay, flank pain, nephropathy, or what do you call it? Some kidney disease. They throw it to you to get an answer. It's not like they are sure. So I just wanted to think that we could pick an organ, like we have picked the pancreas today. It was quite elaborate. And then we maybe go to liver. Maybe the other week we could go to kidney. Thank you.
Okay, thank you, Mr. Ikua. Every good book has got chapters, has got sections and subsections. So this was the book in totality, but you can still fragment, read chapters, subsections. So we can actually plan or organize it. What Mr. said, another slot or other slots, and continue the presentations as well. And we elaborate organ by organ. Also, it's prudent for you guys as you are bringing across, if you have got a specific organ that you need to benefit on, you can actually bring that. Then you can actually organize another presentation for that. We are here to stay, and we're here forever.
True.
Yeah, I second that. So I think at this juncture, the meeting has come to an end. I wish everyone else a good night until next week, Thursday. Stay blessed and keep safe. Remember, COVID is real.
Bye.
Goodbye.
Bye. Thank you so much. Bye-bye.
Good night, Pakistan.
Stay blessed.